All right, hi everyone, welcome back. I hope everyone had a good lunch. We are going to kick off the afternoon session of the symposium now. My name is Amanda Rogers. I am another faculty member here in the Division of Pediatric Neurology, and I'm going to be moderating the afternoon session. We'll start this afternoon with a couple of panel talks regarding some relevant topics in pediatric neurology. Our first talk I'll actually be participating in. We're going to be discussing the multidisciplinary care of patients with pediatric neuromuscular disorders. And several of my excellent colleagues from our MDA Care Center are going to be joining me on the panel. So I'm going to go ahead and introduce everyone, and then we'll go through and each share our talks. So first, to give a little more information about me, like I mentioned, I'm a child neurologist here, and I also am board certified in neuromuscular disorders. I am a co-director of our Muscular Dystrophy Association Care Center, along with my excellent colleague, Arpa Tilicodia. Joining me today on the panel is Dr. Elise McClanahan. She is a pediatric physical medicine and rehab specialist with Norton Children's Physical Medicine and Rehab associated with the University of Louisville. And she's also an assistant professor at the University of Louisville. She's dual board certified in physical medicine and rehab and in pediatric rehabilitation medicine, and has a special interest in the MDA population. Natalie Rimpro is a physical therapist at Norton Healthcare. She is a board certified clinical specialist in pediatrics and has been practicing pediatric physical therapy for 18 years. She has extensive expertise in physical therapy for children with neurologic and neuromuscular disorders, and is also in the process of becoming a Care Duchenne certified physical therapist. Dr. Star Nixon is a pediatric orthopedic surgeon with Norton Children's Orthopedics of Louisville, which is affiliated with the U of L School of Medicine. She's a fellowship trained pediatric orthopedist with significant experience in pediatric musculoskeletal trauma and special interests in neuromuscular disorders, hip dysplasia, limb deformities, and foot and ankle conditions. So I'm going to go ahead and get started with my part of the talk. So as I mentioned, we're going to be discussing together the multidisciplinary care of pediatric neuromuscular disorders. We're going to focus today on the two most common pediatric neuromuscular disorders that we take care of, which are spinal muscular atrophy and Duchenne muscular dystrophy. I'm going to give a very brief overview of the pathogenesis of these disorders, but then focus on some of the disease-modifying therapies that have come about in the last 5 to 10 years, with a specific emphasis on some of the long-term outcomes data that we're starting to get on how these therapies are changing the course of these diseases. So as I mentioned, spinal muscular atrophy is one of the common pediatric neuromuscular disorders that we take care of. It's a disorder of motor neurons caused by a deficiency of the survival motor neuron, or SMN protein. As its name suggests, the SMN protein is crucial for motor neuron survival, and without sufficient SMN protein, patients undergo progressive motor neuron loss, leading to skeletal muscle, respiratory, and bulbar weakness. It's an autosomal recessive condition, and so most patients with spinal muscular atrophy have homozygous deletions of the SMN1 gene, which encodes the SMN protein. Although all patients with SMA have progressive skeletal muscle and respiratory weakness, the phenotype can be quite variable, and in large part is driven by the number of copies of a backup gene that an individual has. And that backup gene is called SMN2. And so, as you might guess, the SMN2 gene is quite similar to the SMN1 gene, but it's different enough that it actually only produces about 10 to 20% of functional SMN protein compared to SMN1. Individuals can have anywhere from 1 up to greater than 5 copies of the SMN2 gene. And so as you might imagine, more copies of SMN2 lead to more functional SMN protein and often a milder phenotype, although patients don't always follow the rules in that regard. As I mentioned, this can be a phenotypically diverse disorder, and we broadly categorize SMA into really 5 different types. I've listed the 4 primary types that we see here. And these are characterized by the age of onset of symptoms of weakness and low muscle tone, as well as by the greatest motor milestone that is achieved. Unfortunately, the most common type of SMA, type 1, is quite severe and is characterized by patients having an onset of muscle weakness and hypotonia before 6 months of life, with patients never achieving the ability to sit unassisted and only an 8% survival rate at 24 months of life. And so, as I mentioned, I'm going to focus a lot of this talk on some of the disease-modifying therapies that we now have to treat this devastating disorder. And as you can imagine, while we want to be able to, and while we do apply these therapies to most of the different types of SMA, the focus, initially at least, has been really on improving survival and quality of life in patients with type 1 SMA. So we now actually have 3 disease-modifying therapies for SMA, and they all function at the end to increase the amount of that survival motor neuron protein that is produced. Nusinersen or Spinraza and Risdiplam or Evrysdi both work at the level of pre-mRNA splicing of the SMN2 gene. So really don't have anything to do with that defunct SMN1 gene, but work on that similar SMN2 to increase the amount of functional SMN protein that is produced. Onasemnogene abeparvovec or Zolgensma is actually a true gene replacement therapy that's given through an IV and uses a viral vector to deliver a real copy of the SMN1 gene to the motor neurons so that functional SMN protein gets produced. Nusinersen or Spinraza was the first FDA-approved disease-modifying therapy for SMA, and it was approved based on the data from the ENDEAR trial that I'm showing here. So this was a placebo-controlled trial with symptomatic patients with type 1 SMA. So these were all infants who had developed skeletal muscle weakness and hypotonia before 6 months of life. And they started treatment before 7 months of life. They were followed over a 13-month period, and patients in the treatment group with Nusinersen had a 61% rate of the primary outcome of no death or use of permanent assisted ventilation compared to the placebo group, where only 32% at the end of that 13-month period had no death or use of permanent ventilation. Patients in the Nusinersen group also achieved new motor milestones over time, which is inconsistent with the natural history of SMA1 and was quite divergent from what was seen in the untreated group. This led to the approval of Nusinersen for SMA, but what has been even more exciting than this trial is the Nurture study. So this is an open label study looking at patients who were identified to have likely one SMA based on their genotype, but who were treated before they had development of symptoms. And so they all had 2 copies of the SMN2 gene, and so would have been expected to develop that severe type 1 SMA, but had normal physical exams when they started treatment. And these patients actually have now been followed for 2.9 years, and they have 100% event-free survival. So all 25 of these patients are alive without permanent ventilation, which obviously after that time period is very inconsistent with the natural history of type 1 SMA. Additionally, all of these patients are sitting without support, 92% are walking with assistance, and 88% are walking independently. The second treatment that was approved for spinal muscular atrophy was Onasemnogene abeparvovec. This is that gene replacement therapy where a viral vector actually delivers a copy of the SMN1 gene to the motor neurons. This treatment was approved based on the START trial, which looked at low dose and high dose cohorts of patients with symptomatic type 1 SMA. So again, patients who had developed onset of hypotonia and muscle weakness before 6 months of age, but who were treated after they had already developed symptoms. These patients were followed for 20 months, and they also had 100% event-free survival, even though they were treated after symptom onset. And the vast majority of patients showed improvement in their motor milestones over time, as depicted on this graph here. And again, this is quite different than what we would expect from the natural history of SMA, which is depicted by this black line here. Again, the even more exciting trial that we have for Onasemnogene abeparvovec, though, is the pre-symptomatic study. So this is called the SPRINT trial. And in this study, patients were identified to have spinal muscular atrophy and predicted to have either type 1 or type 2 SMA based on their SMN2 copy number. So patients in this study could have had either 2 copies or 3 copies of SMN2. And these patients were all treated prior to symptom onset. These patients have been followed for 9.7 to 11.2 months at this point. And they have also had 100% event-free survival, with patients with 3 copies of SMN2 actually all meeting gross motor milestone performance similar to same age normal children without SMA. So on these graphs here, the gray shading represents the time period that you would expect children to achieve certain motor milestones, and then each individual colored line is a patient in the study. And all of the patients with 3 copies of SMN2 are performing similarly to same age children. In the cohort of patients with 2 copies of SMN2, we're seeing really good results. So there are a lot of patients kind of in this normal gray zone. There are some patients who are not meeting milestones on track with typically developing children, but they all do still continue to meet new milestones over time. Risdiplam, or Evrysdi, is the third treatment for spinal muscular atrophy that is FDA approved. It was actually approved on the day of this conference last year, so we've had it commercially available for a year now. We have less clinical trial long-term data on this drug just because it is newer, but we do have some promising results, and they have been very cute and named all of their trials after fish. So that's kind of what I've depicted here to help people remember it. The 2 studies that are kind of most interesting in regards to this talk are Firefish and Rainbowfish. Firefish is a structure similar to the initial trials that we've already seen for Nusinersen and Onasemnogene abeparvovec, where they treated patients with symptomatic type 1 SMA. And those patients were followed over 14 months and showed a 90% event-free survival in those cohorts, which again is inconsistent with the typical natural history of SMA. Sunfish and Jewelfish are studies looking at Sunfish is a study looking at older patients with SMA of age 2 to 25 years, and they've shown the placebo-controlled trial looking at patients receiving Risdiplam with SMA receiving either Risdiplam or placebo, and they've showed motor improvement in the Risdiplam group. Jewelfish is a safety and efficacy study where patients who received Nusinersen or Onasemnogene abeparvovec were either switched or followed up with that treatment by starting Risdiplam, and it's shown that that is a safe and efficacious approach to treatment. Rainbowfish is the newest trial, and this is the pre-symptomatic treatment trial for Risdiplam, where they're aiming to enroll 25 patients with SMA with 2 or 3 copies of SMN2 and start them on Risdiplam therapy prior to symptom onset. They have 21 patients currently enrolled, and the first report of outcomes for these patients just came out this summer at the Cure SMA conference. 5 patients have completed 12 months of the study, and 4 out of 5 of those patients are walking unassisted. And the one who is not walking is standing. So again, very preliminary, but promising data for this treatment as well. The next common disorder that we see in our MDA Care Center is Duchenne muscular dystrophy. So this is an X-linked recessive disorder that's caused by deficiency of the dystrophin protein. What I've shown you on the left-hand side of the screen here is a normal muscle biopsy. Each of these circular structures here is a muscle fiber, and this orange staining is staining for just the dystrophin protein. And so patients with Duchenne muscular dystrophy have muscle biopsies that look like this with complete absence of dystrophin. Dystrophin is important for skeletal muscle integrity, and in the absence of it, skeletal muscle fibers rupture and atrophy over time, leading to progressive weakness, respiratory muscle weakness, and cardiomyopathy, with loss of ambulation typically in the early first decade without treatment. We've treated these patients with steroids for many years, which does prolong ambulation and increase survival, but most children still end up kind of in the mid-teen years at the latest with loss of ambulation. So there's been a lot of interest in doing better in terms of treating these patients. We do now have gene-targeted therapy for DMD as well. The FDA approved gene-targeted therapies that we have are called exon skipping therapies. And this, what I'm showing you here, is an exon map of the dystrophin gene. And what's important about this map is to think of it as a puzzle where all of the pieces need to fit together in order for the gene to appropriately be translated into a protein. So if you're missing part of the puzzle, then puzzle piece 47 is not going to link up with puzzle piece 51, and the protein won't be translated. So what these exon skipping therapies do is actually skip over an additional exon to allow the puzzle pieces to match up again and allow for expression of dystrophin. We now have 4 FDA-approved exon skipping therapies for Duchenne that target exons 45, 51, and 53 skippable mutations, which account for some of the larger percentages of causes of DMD. We have found that these therapies do increase dystrophin production as measured on skeletal muscle biopsy, but really only get patients to producing 1 to 5% normal dystrophin levels. And so whether or not that is going to translate into significant clinically meaningful improvement is still a little bit unclear. Eteplirsen is the first exon skipping therapy that was approved, and so it's been studied for the longest. This past year, they did come out with a study looking at the initial patients treated with eteplirsen and their loss of ambulation over a 4-year period, and compared to age-matched controls of patients who actually had exon 51 skippable mutations. So it's similar of a cohort as they could have gotten. They showed that patients treated with eteplirsen had 80% of patients remained ambulatory after the 4-year period, compared to less than 30% of the historical controls. So definitely worth using exon skipping therapy, but something that people are very excited about is gene replacement therapy for DMD, which is not FDA approved yet, but those of us in the community are hopeful that it will be in the next year or 2. The first paper that came out showing preliminary results from one of the gene replacement therapy for DMD showed an improvement in dystrophin expression after patients were treated with the gene replacement therapy. And compared to that exon skipping therapy, which only induces 1 to 5% of dystrophin production compared to normals, they actually showed 75% of normal microdystrophin production in these patients. Again, the real question is, does that dystrophin production translate into clinically meaningful outcomes? So far, it's too early to say for gene replacement therapy, but at least what they saw in the first 4 patients who received this therapy was that there was a decrease in the CK level, which is a marker of skeletal muscle breakdown and turnover, by 46 to 85%, so quite a bit. And there was also a small increase in the North Star Ambulatory Assessment, which is a motor function assessment that we do use in patients with DMD over a 1-year period. So hopefully these will translate into meaningful clinical results. This is all very exciting, but it certainly also does lead to new challenges and new questions that come up. And so my colleagues are going to talk a little bit about their role in caring for these patients as they're living longer.
Am I next, Amanda? All right, let me see if I can share my screen. Oh,
Slideshow.
all right, can you guys hear me?
Yes, we can hear you.
All right. So my job is to talk about the orthopedic role of treatment of Duchenne's muscular dystrophy and SMA. And in general, I like to think of my job as using tools at my disposal. So our toolbox is bracing and assistive devices, muscular tendinous lengthenings or tenotomies, tendon transfers, where we take a overactive tendon and transfer it to a weak tendon. We can do hip reconstructions. We can change the shape of bones so it facilitates the best use of the muscles. So lever arm dysfunction osteotomies. We can use gait lab analysis to plan single event multi-level surgeries to minimize a downtime, for example. And then we can treat spinal deformity. So in Duchenne's in particular, we have early toe walking and equinus contractures. And in our clinic, we've even diagnosed Duchenne's based on new toe walking patients coming in and meeting the clinical features. Other joint contractures later on, such as in the upper extremities, may become apparent. And there's a high risk of fragility fractures and high risk of scoliosis. So with Duchenne's, in regards to the toe walking and equinus contractures, we really have limited benefit of surgery. I like to think about what Ben Franklin said, where he said an ounce of prevention is worth a pound of cure, and using stretching orthotics like this one in the upper right-hand corner at night will allow the child to continue walking during the day without a heavy orthotic, and also recognizing that the child is toe walking because they are recruiting the strongest muscle available, which is their gastrocsoleus muscles, and the putting a brace on them might completely decompensate their gait. So other joint contractures are rarely treated with surgery. You can use maybe dynasplints or other splinting methods, particularly at night. But we may do surgery to release contractures if we have a treatment goal that's reasonable, like for, help them dress, get their arm in a sweatshirt, or get their pants on, or help make diapering easier, because in general, these joints that are contracted are weak. And by releasing the contracture, you're not necessarily going to do anything but increase range of motion, passive range of motion. Fragility fractures also, think about our friend Ben Franklin. We need to prevent more of these rather than treat more of these by maximizing bone health. And then if we do have an unfortunate incident where the child falls out of their wheelchair, for example, we want to treat that appropriately, minimizing need for surgery. And if it's an ambulatory child, consider the best way to fix the bone that allows them to keep walking. And that's particularly important with our Duchenne's kids, that we try to keep them walking as long as possible. Scoliosis being common also progresses fairly rapidly, and there's an earlier push to fuse these children than in our adolescent idiopathic scoliosis group, in which case we take a more conservative approach. So since scoliosis is one of the few things we more often intervene surgically in with Duchenne's, I'll talk a little bit about that. So again, it's common and it's frequently rapidly progressive. And as it progresses, the pulmonary function worsens, and the curves, as they worsen, exacerbate already difficult positioning. So, you know, the pelvis can hike up on one side, the ribs in the pelvis can actually impinge on each other, causing pain, and that obliquity of the pelvis causes uneven weight placement. And it's sometimes we can only adjust a wheelchair so much before there's pressure sores and whatnot. Also, in the concave side of the curve, there can also be skin breakdown, because these are really not very flexible curves. Again, just to reiterate, this is not comparable to treatment for adolescent idiopathic scoliosis, which is the most common scoliosis you think of in healthy kids. Bracing is not effective at minimizing progression. So in general, for those that do need surgery, again, we're intervening earlier with smaller curves, definitive fusion, particularly for those who are already in a wheelchair. We might start at 20 degrees because we know that they're just going to get worse. We need to consider the cardiac function of the child and consult or involve our cardiac team preoperatively. Typically, to minimize blood loss in healthy kids, we use a controlled hypotensive anesthesia, but that may not be well tolerated by kids with cardiomyopathy. And so we also have used TXA in all of our spine patients as a standard of care to minimize blood loss. Pulmonary function can be optimized pre and post-op. Teaching kids assisted cough techniques pre-op can help, as well as using post-op BiPAP. But we also need to tell them there's a very good chance that they might wind up in the ICU with prolonged post-operative ventilation, and that they should be aware of that. Special concerns for the anesthesiologist should be taken into consideration. Total IV anesthesia is recommended to minimize the risk of rhabdo and life-threatening hyperkalemia, and depolarizing agents are contraindicated, for example. And there's a much higher risk of postoperative infection in any secondary scoliosis, including Duchenne's, so they frequently will develop infections that require washout. And to minimize that, in addition to IV antibiotics at the time of surgery, we're also using vancomycin powder within the wound. One thing for our therapists and our PM&R colleagues to be aware of, and the patient and their families, is that fusing these kids can lead to decreased neck movement, and that may compromise self-feeding in kids with Duchenne's. So with all those terrible risk factors and potential complications, why should we fuse these kids? Well, there's not really a clear benefit of whether fusion improves respiratory function or not, but certainly keeping the spine from progressing to a 60-degree curve probably helps minimize worsening of function, but I don't know that we can show that it reliably improves respiratory function. And it certainly doesn't reliably improve the quantity of life, but it does in studies show that it improves the quality of life by improving sitting tolerance, improving positioning, and then caregivers perceive that the care of these children is easier. So those are things to take into consideration. And again, surgery for spines and Duchenne's is we use a shared decision-making model like we do with just about everything else, and talk about risks and benefits and help the family come up with the best decision possible. So moving right along, we'll go on to talking about how I help with the management of kids with SMA. And this is really mainly kids with type 1 and type 2 SMA, because they're the most involved in terms of orthopedic care. So back in the day, just a few years ago, a child with type 1 SMA who's a toddler would be completely vent dependent with 100% risk of a hip dislocation and scoliosis. joint contractures, fragility fractures. And then in the type 2s, they would also be very high risk for progressive scoliosis as they got older. And we were more likely to use a standing program in the type 2s to help prevent risk of contractures and help promote bone quality, but also very high risk of hip dislocation. And the type 3s and the type 4s, they very rarely need anything from us, because if they do get scoliosis, it tends to be later in life, and most of their stuff is managed with functional therapies. So now with our kids with SMA, here's our, child who was on Spinraza, and her mom gave us permission to use this picture. She stands and walks with support and is a complete whiz in her wheelchair and completely independent with ambulating in a self-propelled wheelchair. But we have this uncharted territory. The textbooks say that kids with type 1 SMA are going to die as toddlers. So don't, make them miserable by doing all these unnecessary surgeries that aren't going to prolong the quantity of their life or improve the quality of their life. But now we have a child like this young girl who, children that have scoliosis and hip dysplasia, and they aren't going to die as toddlers, but they may have significant functional limitations because of their severe scoliosis and hip dysplasia. So now we need this new phenotypic descriptions for these children who have had treatments and which treatments they've had and what age they started, et cetera, et cetera. And then we need new treatment recommendations given the improved prognoses, because that's just not out there. And for us as orthopedic surgeons, the board answers have changed a lot in the past 2 years. So unfortunately, we still are seeing very high rates of hip dysplasia. In that top picture, the femoral heads are sitting about at least 50% out of the socket. That's neuromuscular hip dysplasia. And then here's a supine radiograph of a child under the age of 2 with a 63-degree curve. And that's not even with her sitting. So that would presumably be much more significant had we been able to get seated scoliosis x-ray, which again is the standard for measurement. So what do we do for these kids? We go back to our orthopedic toolbox. We do bracing, we use assistive devices. In regards to lengthening, or rather cutting tendons for tight tendons and whatnot, really that's not as indicated as it is perhaps in, say, cerebral palsy, because we also don't want to make these already weak children weaker. Tendon transfers, depending on which muscle is working and which one isn't, may be an option, and depending on what problem you're trying to solve. These kids will be, and the new recommendations are, instead of leaving the hips out of the socket in the type 1 SMAs, as they get older, if they need it, we will be doing bony surgery to replace the ball or the proximal femur within the socket or the acetabulum. We also, as they start to walk, may consult our gait lab and do formal evaluations of their gait and figure out if cutting and turning bones, for example, puts their foot in a place and space that's more advantageous for walking. And then we will certainly be continuing to treat the spines for these type 2 SMAs, which we always have, but also now doing surgery for type 1 SMA kids who have, like we are seeing, pretty significant spine deformities. And the unfortunate thing is, well, the fortunate thing is they're living, but the unfortunate thing is they have severe curves at a young age, and we need to use our growth-friendly techniques. Now, this is probably going to change with earlier screening and earlier treatment and use of gene therapy rather than, starting Spinraza at 4 to 5 months, which was helpful, but also probably allowed the spine to progress. So at any rate, maybe we won't see such severe curves in the kids that have been treated from an earlier age. But again, nobody knows. No, we have no idea, but we'll be ready. So the younger patients are going to get growth-friendly spine surgery, and that sounds really nice because these are implants that, in theory, grow with the patient, but they only grow for a time, and eventually they need to be replaced. It's really not clear how surgery influences pulmonary function, so we can't reliably say if fixing or fusing that or guiding with magnetically controlled lengthening implants, if that is going to improve the pulmonary function of that child with a 60-degree curve. We have no idea. There's really and hopefully keep it from getting worse, but we can't say it's going to make it better. And again, none of our data from the CP literature or Duchenne's or any of the other surgery or other neuromuscular kids would indicate that, doing guided growth of the spine is going to minimize decline of the lungs. But we're going to figure it out as we go. And then hopefully it would minimize the rate of progression by putting, say, a magnetic growing rod in the spine and help giving it some, like a trellis, if you want to think about it, or like a tomato vine growing up a stake, kind of give it a place to grow and kind of help keep it straight, should minimize the rate of the progression of these curvatures. But at what point do we intervene? I mean, some of these kids had severe curves dating back to when they were 6 months, 12 months of age, and they're teeny tiny, and these are big metal implants. I mean, we're kind of limited by the implants that we have, and unfortunately bracing may help with positioning and helping the gain neck control and whatnot, but I'm not sure that bracing really helps minimize the progression of scoliosis that much, but it's something. There is, unfortunately, like with the Duchenne's group, a high complication rate with surgery for these kids. Any neuromuscular patient or secondary scoliosis patient has a much higher risk of infection compared to the idiopathic scoliosis group. There's always a risk of wound breakdown. Some of these kids are super skinny, maybe have poor nutrition, have little soft tissue coverage, and now you have a metal implant sitting under the skin. Again, wound breakdown is a very real risk. And then even though these implants are not supposed to fuse the spine, they may inadvertently fuse the posterior elements of the spine, which then unfortunately still allows the anterior aspect of the spine to grow. And then we get something called crankshaft. So that can happen inadvertently. And then again, like I said, patients actually have to be physically large enough for these implants to fit in them. And so it's a very hard waiting game for many of these families who are watching their kids' scoliosis progress, but their kids just not physically big enough for us to put the metal in them yet. So here's an example of a magnetic growing rod. You have this severe curve. I would estimate that 60, 70, maybe even 80 degrees. And then we have the growing rods, which have done a good job of preventing it from progressing over a period of time. But you can see these are huge, there's huge metal screws and big bars that are sitting, fairly subcutaneously. And so those are some sources, and I'd be happy to answer any questions. This is really just the tip of the iceberg for a complicated subject.
Yeah, let's go ahead and move on to Dr. McClanahan and Natalie, since we're starting to run a little short on time, and I'm going to answer questions just in the chat rather than doing them verbally.
Okay. So I'm going to take just a few minutes here to discuss some of the physical medicine and rehab considerations in these patients. This is by no means a fully comprehensive view, but just kind of some of the basics of the things that I look at. So physiatric management for these children with neuromuscular diseases, particularly Duchenne and SMA, focus heavily on function. So we want to keep these kids doing anything they want to do and being as mobile as possible, whether that be by ambulation or with some kind of assistive device. And typically mobility is the primary consideration for patients and families. And this includes evaluation for bracing, equipment, and different therapies. So in terms of Duchenne muscular dystrophy, it's important to remember the highly affected muscle groups. So your leg muscles are typically affected first and not in a symmetric way. Certain groups are more affected than others. So typically you see hip extensors and hip abductors more affected, as well as your knee extensors, so your quadriceps, and then your ankle dorsiflexors and your everters. So this creates that kind of classic gait pattern that you see with Duchenne muscular dystrophy, which is a lordotic posture, and that's helping to compensate for that hip extension weakness. You also have a waddling Trendelenburg gait, and that's due to your hip abductor weakness and forefoot initial contact. So these kids walk on their toes to help lock out their knees for more stability as they're walking. And that's really important to remember when you're looking at any kind of bracing for these young men. So kind of as Dr. Nixon mentioned, we're in a little bit of uncharted territory with spinal muscular atrophy. A couple things we do know is that early power mobility is excellent for development. There are a number of papers that have been published supporting this, and it's really trying to mimic typical developmental milestones. So, as you know, children are expected to start walking around 1 year of age. So we look into early power mobility as young as 18 to 24 months in some of these children, so they can mimic that typical toddler age for ambulation to help explore their environment and gain a lot more independence, similar to their typically developing peers. It is important to emphasize, though, that even if you are looking at powered mobility or any kind of wheelchair mobility, that ambulation can still be a goal. Families tend to get very focused on if you put the child in a wheelchair, they perceive that as that you're giving up on their walking. And that's not the case. It's more promoting independence in the best way possible, because a lot of times still at this point, these children are not overly functional with ambulation, so they don't necessarily have a lot of independence with it. Another thing we look at in these disorders is exercise. So you look at it a little bit differently based on the two different diagnoses that we're talking about. So the dystrophic myopathies like Duchenne, you have instability of the sarcolemmal membrane, which predisposes it to injury from mechanical loads. So you have to counsel these boys to avoid eccentric muscle activity and high resistance activity. And some of the ones that are staying a little bit more functional a little bit longer, this is important because they want to go out and they may want to try to lift weights and try to build their muscles, and that's not necessarily safe. So we recommend a submaximal aerobic exercise for them in order to stay active. So in the motor neuron disorders like SMA, you don't really have any muscle pathology. So you encourage activation for strengthening. So aerobic exercise, general conditioning with or without resistance, and then either eccentric or concentric muscle activity is fine for these children. And Dr. Nixon mentioned this a little bit as well. It's really important to remember stretching and contracture management. Some degree of contracture is usually inevitable with these diseases at this point, given kind of the dispersion of muscle weakness, and especially Duchenne, how there's a lot of imbalance in how the certain muscle groups are weaker than others. The multiple factors will contribute to this contracture. You have degree of fibrosis and fatty infiltration of muscle. Static positioning is really important. So if you're not walking much, you're staying in a seated position, which means your hips and your knees are flexed, and you're not getting as much of that passive extension as you might if you were more mobile. Imbalance of agonist and antagonist muscle strength across a joint. So again, if you're seeing more ankle dorsiflexor weakness, you're going to have it overpowered by your plantar flexors. So your foot is going to be more pointed down. Lack of upright weight bearing, and then compensatory positioning for biomechanical stabilization. Stretching and range of motion, in order to be effective, should really be performed 5 times a week. So it's really important to emphasize to these families that these things need to be done every day if you want to see benefit from it. And bracing plays into this too. So nighttime stretching braces are strongly recommended. Again, need to be applied ideally every day, but we'll say 5 times a week to be effective. So these are, braces that are holding that stretch across a joint. So maybe holding the foot in a more neutral position, keeping your knees extended. A lot of times we'll say if kids can't sleep in it and they can't tolerate it, we'll say just wear it for a few hours in the evening if they're watching TV or playing a game or doing homework, just to get some sustained passive stretch. And as I mentioned, with the distribution of muscle weakness in Duchenne muscular dystrophy, daytime AFOs are not usually recommended for kids with Duchenne's, and that's because they're using that foot pointed down in order to maintain knee extension during gait and maintain stability. So if you brace that, you may actually make it a lot more difficult for them to walk because you're taking away one of their stronger compensatory muscle groups. And then Dr. Nixon also briefly mentioned TLSO, kind of jury's out on how much it really slows development of scoliosis, but it can help support sitting, which is it can be a very useful goal. A lot of times these kids will need an abdominal cutout just because of either if they've got a G-tube or sometimes they have a more bell-shaped abdomen. So it's just really uncomfortable if they don't have that. And then bracing for SMA is much more patient dependent. So if, they've got a foot that somehow ended up more downward pointed, we would recommend an AFO because it's not really a mechanical advantage for them to maintain that. But it's, since they're not really specific, they don't follow a certain pattern of weakness typically, so it's going to be a lot more patient dependent. And then we also look at durable medical equipment and assistive technology. So in Duchenne, you anticipate transition to wheelchair mobility when their knee extension strength is less than 3 out of 5, so less than anti-gravity. And a lot of times we follow their 6-minute walk test. And we have some other functional testing that we do for these kiddos. But a big one is the 6-minute walk test. And once they are unable to walk 325 meters is usually when we're looking at a wheelchair. And power mobility is often the most appropriate for Duchenne. They're typically anticipate you're going to see a lot more arm weakness, and it takes a fair amount of upper body strength to self-propel a wheelchair. So even if they've still got good use of their arms, it won't necessarily be appropriate for self-propelled wheelchair. And then you need to ensure adequate postural supports are present to support scoliosis. A huge thing we recommend for non-ambulatory children over 2 years of age is a stander. It's developmentally appropriate for these children to be standing, and it's really good for them. There's so much research on how it helps development, it helps gut motility, and it helps bone health. And we do worry a lot about bone health and increased fracture risk in these children. And then you have other adaptations. So mobile arms to increase your upper limb use, especially as these Duchenne kids keep aging. And then augmentative communication. So as if there's difficulty with speech, you can look at eye gaze devices. And there are also different supports that you can get to help with game playing. A lot of our Duchenne young men really enjoy video games, and as they progress to later stages and their hands are weaker, that's difficult for them, but we have adaptations that we can look at for them. So I would like to pass this along quickly and let Natalie have a few minutes to chat with you as well.
Hello, everybody. I'm going to go through this really quickly and just mention some of the things that my colleagues have not said. But my role as a physical therapist at the Multidisciplinary Clinic is to promote function, wellness, and being, just improve the quality of life of these kids. I'm also your numbers girl, so I'm going to gather data and get as much objective information as I can, and then give input and educate the family on my recommendations. And then most of the time people have their own therapists in these rural communities, and those people don't get to see as many neuromuscular conditions as I do. So I call their private therapists and just try to collaborate care together. I always think 2 brains are better than 1. I'm going to take a lot of objective measurements through outcome measures, and I'm going to talk briefly about them today, but usually they're needed for authorization for insurance. Like the SMA kids that are getting Spinraza, these insurance companies want to know their scores. So that's one of my purposes. And with SMA in particular, I'm going to look at all of the first column, so all these objective information, and then I'm going to look how they function in society with those activities, and then how do they participate? Are they going to church? Are they going to school? Are they involved in any kind of sports or anything in their community. And I will say with the pandemic, a lot of these kids that were kind of at risk for, maybe getting COVID end up staying home. And so I feel like a lot of them have really progressed quicker than they would have otherwise. So there's a lot of different outcome measures I could look at for kids with SMA, and here's just some of them. And I like this graph because it shows me I can do the CHOP in 10 for a kid that can't sit yet. I can do the Hammersmith for a kid who can sit and walk, and you can read the rest, but I'm going to go through these rather briefly. And I want to show you, if there are any physical occupational therapists out there, this link through curesma.org. You can go to this website and click right here where it says download toolkit for physical therapists. And it gives you this 104-page active PDF file, which I love. It's very resourceful. Oops. Sorry about that. I would like to go to page 27 and I'll show you. But it has this nice table. It shows you different outcome measures based on what skill level they can achieve. And you can click on this. So let's say I want to do the CHOP in 10, which stands for Children's Hospital of Philadelphia Infant Test of Neuromuscular Disorders. And this one's very common for SMA population. And it briefly describes it. And it also gives me a link to where I can find this. This one is available online for free. And then again, I click on this second column, and here's what the test looks like. So it briefly looks at active movement of their arm, their hand, their neck, then it goes on to their legs and their shoulders. And it also then looks at anti-gravity or gravity eliminated positions, looking at leg, again, head, neck, and then their paraspinals, their back extensors. So that is a great resource to use. And then some other ones for SMA are the motor function measure. You can also use that one for any of the Duchenne or muscular dystrophies. The Hammersmith is a little bit more detailed. It's for kids who you get into the crawling on hands and knees, get into kneeling and some walking skills. We can look at muscle strength with the dynamometer. The revised upper limb module I haven't done yet before, but it is just like it sounds, looks at the arm function, and an OT would be really good to do that. The Brooke upper extremity scale is super easy and quick. And then these timed graded functional activities are really easy to do. So if you're a physical therapist and you're seeing a kid with a neuromuscular disease, it's nice to track their progress or progression over time doing these different tests. So timed up from the floor, just like it sounds, how fast can they get up from a laying down position to standing up? And then how fast can they walk 10 meters, turn around, back to sit down? How fast or how long can they go for a 6-minute walk test? And then stairs, just like it sounds. And then 30-second sit to stand is how many times they can stand up from a sitting position. Some other of the outcome measures for the dystrophies are the North Star. That's a very common one, and it's super easy to do. It's also available online for free. And I think it's just one page of skills, standing on one leg, jumping, sitting up. It's pretty simple to do. And that is, again, used in a lot of these research studies for kids with Duchenne's. And you can typically start using it at about 3.5 or age 4. And then for kids that have progressed and they are no longer ambulatory, I give the Egan classification, and it's just a quick 2-page questionnaire. You do a little bit of objective measuring, but otherwise you just ask the family and the patient about their functions. It has to do with eating and sleeping, and can they maneuver their wheelchair themselves, and can they lean over to the side in their wheelchair? And it's nice to track that over time as well. And then the blue circle in the middle are outcome measures for either or, ambulatory or non-ambulatory kids. And at our
Natalie,
clinic,
right there, I'm actually sorry, I'm gonna have to
okay.
interrupt you, and we'll have to wrap up because we're running 10 minutes over now. Sorry, I'm at fault for that,
That's
but I
okay.
definitely want to give some time for our next panel.